I will now introduce our speaker, Justine. Please come over here. And Luca Corradi, our Innovation Network Director, who brought Justine
Good afternoon.
to talk to us. Justine, could you tell us a bit about yourself?
Yes. Is my mic working? No. It's good. Hang on. Far enough. There we go. Fantastic. So my name is Justine Royle, and I, as it says on the slides, I'm a consultant urological surgeon. What that means is I spend my life making men impotent and incontinent. So I mainly, during my day job, deal with prostate cancer. So that's how men get impotent and incontinent as a result of my hands. I do other stuff as well, but that is the main thrust of what I do at work.
Can you tell us a bit about what you'll be talking today?
So as part of my day job, surgery has progressed a lot over the last 20 years that I've been working in it. And a lot of those technologies that we use are also similar to a lot of the things that you use in the oil and gas industry, which is how, obviously, Luca came to see me to discuss the similarities that we have and what we could potentially learn from each other.
So I think Justine already answered what I was about to ask you, Luca, but if you would like to add anything, why did you think that robotic surgery would be relevant today for the OGTC?
Well, there's no doubt that robotics is one of those technologies that span across industrial sector and areas of life and work. But robotics also came in very many shapes and forms. Some are autonomous, some are less autonomous. It's about how they move, what they do. So we are, as part of the Gas Technology Center, we're looking at robotics on its various form, and what we see in the manufacturing industry is different from what we see in the surgical industry or sector, if you want to call it. So I thought that is good for the oil and gas audience to understand different type of robots, and that will trigger thoughts and innovation, and then can be implemented and adopted across sector, and that's part of the purpose and the philosophy of this kind of events and talk.
Thank you, Luca. Thank you, Justine, for being here today. If you're ready, your 20 minutes start right now.
Thank you very much. So if you're in the medical profession, you're always used to declaring your interests, shall we say. So a lot of the companies that I speak for produce oncological products, so I'm duty-bound to put those up, and they're on the slide. The most important one from my perspective is the bottom one. I am absolutely in love with my robot, which is a Da Vinci system. That's why it's called Da Vinci. Okay. So I'm afraid you can't invite any medical professional out and not expect us to do a bit of health information and health promotion as well. So I'm going to throw that in there as well. So I can't go anywhere without talking about prostate cancer, so I'm going to do that for a bit. And I'm also going to talk about the technological advances within my field and some of the parallels that they have within the oil and gas industry. So I'm going to get the health promotion out of the way. So in the corner of the slide, you'll see the emblem of UCAN. UCAN's a cancer charity that works in the Northwest. It's close to my heart because it paid for my robot. And it does a lot of work in urological cancers, of which prostate cancer is one. And it's prostate cancer that I spend the vast majority of my time dealing with. I think it's important because 1 in 8 men will get prostate cancer in their lifetime. That's a big health burden. So there's a lot of chaps in here. And a significant proportion of you lot will get it at some point in your lifetime. One of the most important things that's happened lately in terms of looking at the mortality rates for cancer across the UK, it used to always be that the death rate for prostate cancer was lower than that for breast cancer. And that changed this year. And I think that's a real shame. And I think we as a group of clinicians often think that that's down to the way that a lot of health promotion is done. So I'm sure most of you are aware that there's a big breast cancer screening programme. One of the things that the government doesn't like is screening for prostate cancer. Now, I'm obviously going to present you a biased view. I clearly think that screening for prostate cancer is a good idea because it keeps me in work, but also because this death rate going up is not an artifact, it's real. So why are these men dying from prostate cancer? If we can diagnose them early and treat them earlier, then we're going to prevent that, and we're going to see the same effect that we hopefully are already seeing in breast cancer, where the death rate from prostate cancer will go down. And I think the most important thing is the one at the bottom. So prostate cancer doesn't give you symptoms. until it's too late for me to cure you. So if you've got symptoms related to your prostate cancer, by definition, usually by the time you come to me, you've probably gone to the point that I can't offer you a cure, which is a real shame. So this is looking for an asymptomatic cancer and helping to hopefully prevent your ultimate death from it. So, how do we find prostate cancer? So there's a blood test, which is something called PSA, that you can go and have with your own general practitioner. As a blood test, it's all right, but it's not great. It gives you clues as to who you should be looking at. But it's not that accurate, and it doesn't tell you for certain whether you do or you don't. So you then need to undergo diagnostic tests. And this is the first parallel that I would give you with the oil industry. So this is something called a truss biopsy. So basically, I'm standing in front of the bottom, but you can see there's a bottom over here, and the gentleman's got a probe up his bottom. That's that grey thing there. And then we're sticking needles into his prostate gland. So that's how we find prostate cancer, and that's how we diagnose it. Well, that's what we have been doing for the last 20 or 30 years. Before that, we just used to stick a needle at the bottom, and we didn't even use ultrasound. So the parallel that I would give you is perhaps this is a bit like in the old days when they used to work around Texas, and they used to think, oh, that's like a good place to put a drilling well. We'll just stick it there. Yeah, so that's a vague idea that there's something going on down there. Let's go for that and drill a few holes and see what we get. And then the next stage is you perhaps use some ground-penetrating radar or something similar. So that's your ultrasound equivalent to vaguely give you an idea of where the prostate is. So it tells you where the prostate is, but it doesn't tell you where the cancer is. So what can we do to try and tell us where the cancer is, which is like trying to find the oil in your guys' hands? So what's new? Okay? What's new? So one of these is new. This is a Senthal. Okay, so Senthal's very dear to my heart. He's a radiologist. So I'm a surgeon. This guy spends his life in the dark looking at pictures. And the thing that Senthal does for me is he looks at MRI scan. So you guys have MRs, I believe, that you stick down your wells to try and figure out what's going on around your pipelines, this kind of stuff, to give you a plan. Well, we do a similar thing. So we do MRI-guided prostate biopsies. So this takes that MR that Senthal's had a look at for me. So this is an MR image here. Sorry, it's not projecting very well. So magnetic resonance imaging gives us some clues about how the prostate looks. So we've had that for years, how the prostate looks in terms of its structure. But what we also have now is how the prostate behaves in terms of its function. So this is called a multiparametric MRI. So you take multiple images at different points, and it tells you how those tissues are behaving. So that's very similar to how when you're looking down your and logging your wells, how the technology is behaving down there. So it produces different curves. The curves tell you about the tissues and substances around it. So we use that to then accurately guide our areas of interest. So we still have the ultrasound probe at the bottom. We haven't advanced that far yet. So that's the ultrasound image at the bottom. But we then overlay the MR image on top of that to tell us where we're going to go. So it's a similar sort of location finding process that we have as to what you guys use MR for in the oil industry. So is it any good? Well, the answer is yes, it is in urology. So a conventional biopsy, where you get the right patients to look for your prostate cancer, we find prostate cancer in about 40 or 50% of the time. If I go for an MRI fusion biopsy, and I think that I've seen something on the MR, the yields become much higher. They come between 50 and 100% in some cases. And that's quite useful because sticking things up gentlemen's bottoms is not a nice thing to do to them unless you really have to. So that helps us out. Now, quick caveat, can I just check, is anybody very squeamish? Because I do have a couple of slightly bloody slides, and if you do, if you just feel faint, we have apparently a first aider. I'm no good at first aid, but we do have a first aider. Just, you know, let us know or look the other way, so that, because those slides are coming up fairly soon. When you're appointed as a consultant surgeon, you think you have reached the pinnacle of your profession. You think you are great, and you think that it doesn't get much better than you. So when I came to Aberdeen, I was the first person in Aberdeen to do a keyhole prostatectomy operation. So I thought I was great, and I thought there was nothing better. Because for years, we've been doing this. So this is basically the hole that you make in the belly to try and get into the abdomen to take a man's prostate out. So the idea is you make a hole big enough to get your hands in to take a prostate out, which is this kind of size, and then join him back together again without damaging any of that important clockwork and without making him impotent or incontinent, which is risks. But what I was doing was this. So this is the inside picture from a keyhole prostatectomy. So this is a laparoscopic procedure. So this is the next phase up. So for patients, it's great. You halve the inpatient time. They don't bleed. Their recovery time is much shorter. Their continence rates are better. Everything else is better. So you can see there's two instruments here which go in through small holes. And then there's a prostate down here. I've just tied a knot there. So that's the kind of instrument that we use for that kind of thing. It's nice and light, because I don't like the strain on my shoulders, but it's straight. Doesn't do what I can do. But I thought I was brilliant, because I could do this. I was wrong. And being older and wiser now, I know I was wrong. So the next phase up was this kind of thing. So this is what we now have in Aberdeen. This is a version of my Da Vinci. So we have, this isn't me here, I'm sat over there with the fat bum on the corner there. So we have the patient here, and then you have a system which docks into the patient. You have basically the computer processing bit, and then you drive it from over here. We describe it as being up the elephant's bottom. It looks a little bit like that. But basically, you sit remote from your patient and do the operation. Now, that sounds a bit foreign to most surgeons, and you think that can't possibly be a good thing. It's not a good idea, and this kind of stuff. You know, I've reached the pinnacle, I can do this operation, nobody else can do it. But actually, when you think about it, what you want is not one surgeon doing the operation. You want a shed load of surgeons doing the operation and doing it well. And that's what this system allows you to do. Can I have a quick volunteer? Come on, Luca. Looks like it's you. So I just wanted to demonstrate to you the difficulties that we have moving from open surgery to keyhole surgery. Can I have you kind of there? So sugar cubes. We actually do use these in surgical practice for training our junior surgeons. So I will give you the analogy that if you were doing an open operation, you would be, say, looking at you lot while trying to stack those with your hands down there, because you can't have your head in and do the operation at the same time. So Luca, if you would stack the cubes for me. Keep looking over there. You can occasionally look down, which is what we would do. So Luca's managed that reasonably well, and that's because he could feel what's going on. So when you do it keyhole, you have a flat screen to look at. So obviously when you're looking at that, you see it in 3D. When you're doing it keyhole, you actually only see it in 2D. So I was going to put a blindfold on in one eye, but we'll make it easier for you. Okay, so these are laparoscopic instruments. Usually you wouldn't be allowed to wiggle around, but we'll make it easier for you. We'll even let you see.
With 2 eyes.
With 2 eyes. Make it easier for you. So you can see Luca has been practicing. You're doing well. I should have put the blindfold on.
Yeah, with 1 eye.
It was much more difficult with 1 eye, isn't it? So before he was doing it with 1 eye, it's much trickier. Even so, he's managing very well. You've obviously got a career in surgery if the oil and gas thing doesn't work out. Although I have to say, if he was my trainee, I'd be shouting out, 2 hands! Okay. And then your assistant does that to you, really put you off. You see, he's determined, isn't he? Determined. Oh, you see 2 hands? It's much easier. So there you go. So that's a demonstration of the difference between open and laparoscopic surgery. Thank you, Luca. Laparoscopic is much trickier. It takes much more training. He's only had 10 minutes this morning, and already he's not quite there. But what robotic does is it takes a lot of that difficulty away from us. So how does it do that? So what you get when you buy one of these things is you get this thing, elephant's bottom as we describe it, your central processing unit and your spider that docks into the robot. So obviously you need that to give you access. What you get when you look down is exactly this. So rather than having fake 3D, which you can obviously have with these systems that you have with goggles, I just sit on it with my normal glasses and I get a different image in each eye. And it's the same as when you look down and you look at anything else in 3 dimensions, it gives you a 3-dimensional image, which is a real 3-dimensional image rather than a fake one created by a system. So it's proper 3D, which if you're trying to perceive depth, as Luke has just demonstrated, it's quite tricky. So that's one of the things it does. The next thing it does is this. So I was talking about straight sticks that Luca was using before. Yeah, nice, straight. So if I want to go around the corner, I've got to go backwards and upside down. Yeah, so it's pivoted and it's reversed. With the robot, so this is a robotic instrument, what you can do is it's got a wrist already on it. Yeah, so it can bend at these junctions here, and it can go, and it's actually got more degrees of freedom than my wrist. So it can go around the corner more. What I'll often do is if I'm trying to get around a very tricky bit, I'll put it halfway, then take my wrist off and do the rest by reapplying my own wrist, because it's got more flexibility inside the patient than I have. So a definite improvement. So it allows me, so there's a stitch that's being done here. So this is an image from robotic surgery, and you can see the instruments here. They're flexed slightly as my wrists would have been if I was usually doing an operation, and there's a stitch up the front like that you can't do in real life. You can do it just about if you're able to get in, but you certainly cannot do it with a straight stick from the side. It just doesn't work. And this allows you to do it without even thinking about it. It's very easy. And it takes away all of the translation that you have to do in your head. So what takes so long to train to do somebody laparoscopically is obviously when I'm doing that, it's doing the opposite. So you have to think about every movement that you make. You actually have to do innately what's the opposite. With robotic surgery, you do that, robot does that. Works really nicely. And it is almost entirely intuitive. The company's called Intuitive, and it is actually very well named because these things are completely intuitive. But I was a bit of a Luddite, as you saw in the cartoon earlier, and I thought, you know what, I can do robotic surgery, laparoscopic surgery, it's every bit as good, and it's better and produce results. So we got the first robotic system in Scotland in August 2015. And I thought at that stage it was going to take me at least 6 months before I was happy that my robotic results were anywhere like as good as what I was achieving laparoscopically. In reality, it took me 15 cases, which for me is probably about a month's worth of work. It's incredibly easy to use. So I was saying before, I use the analogy, I've two smallish boys, and they were even smaller then. And when we were trying to raise money for the robot, small boys came along with me, and we sat who was then 6-year-old, down on the console to have a go and see how he ran it. And he picked it up and did it, and did the exercises involved in the surgery without any hassle, and that's a 6-year-old. So this is incredibly easy to drive. So this is like, if you like, one of your ROVs that we use under the sea. So this is a remotely operated vehicle, so I'm remote from my patient, but it allows me to operate in very tiny confined spaces, and that's the big analogy that I would say. Obviously you guys deal with quite confined spaces under the sea, difficult to access. I do that all the time because, believe me, prostates weren't designed to come out. So what's going to happen with robotic surgery in the future? So obviously we were at the cutting edge a while ago, but things are progressing. So obviously, from my perspective, I'd like to see increasingly accurate diagnosis. Prostate cancer is a tricksy beast to diagnose. We still miss the odd ones, but we've got to drive those death rates down. I think we're going to see increasing miniaturization of the robots that we use, and we've already seen that in our sector already, where the size of the instruments, so we call it French, I don't know what you call it in the oil and gas industry, but the French is the outside diameter of the instrument. So these are quite broad. These are 8 French. And what we would like to see is that going down to about 3 or 4 French, so that the holes that they're put through are even more tiny. Smaller holes, faster recovery, get out of hospital faster, less complications. More time you spend in hospital, more complications, bad idea. The other thing that I think is starting to come through and will increasingly come through is image overlay. So you've seen how we use image overlay already in the MRI, ultrasound diagnostic sector. So what will become increasingly apparent and used, I think, for us in robotics is image overlay when you're actually operating. So this is real time, have your CT or MRI scan basically piped into a corner of your eye. So the technology's there already to do that while you're operating. You overlay the image, so you do the synchronization, say when you're operating on a kidney, and you say, right, okay, well, the top of the kidney's there, the bottom of the kidney's there. The tumour that I can't see is going to be here, so I'm going to make my incision there, and it will allow you then in 3D to know exactly where you're going and to produce a better result. So you don't have to make as big a hole, you don't have to be as exploratory when you're dealing with smaller tumours that might cause you problems. Just thought you'd like another close-up of my baby. So I didn't want to put too gory anything on there, but if any of you do want to have a look, that's a link to, it's not anything horrible at all, it's a grape being peeled, and that just shows you the utility of this type of robot that we have, that you can use it for basically peeling a grape and stitching it back together. So not only taking the peel off. So if anybody does want to have a look, that's what that link is for. Thank you very much.
Thank you very much, Justine. That was a very interesting presentation and demonstration. Thank you. We will move on to the Q&A. So if you have any questions for Justine, Lauren is waiting for you with the mic. Wait for her to reach you and please ask away. Do you have any questions?
That was a fascinating, swift demo of all this work. I'm a psychologist and I have done a little bit of work on surgeons' intraoperative decision-making. And I'm wondering what your view is on, do you think there's any shift in your decision-making, in your risk-taking when you are remote from the patient with your head up the elephant's bottom instead of there with your hands on flesh?
Yeah, I would say there's no question that your ability to take risk becomes higher. I think some of that is sex dependent. So I think risk-taking behaviour in surgeons is probably more prevalent in men than it is in women. I think I see that in surgical trainees. One of the problems that we have to overcome is this whole business when you're operating on people that you don't really want to cause them injury. So making holes in them and this kind of thing is difficult. So I find that difficult because I don't like blood and I don't like needles. So I'm actually needle phobic. It's not great for a surgeon. But if you think about it, it is great for a surgeon because they don't want you to spill your blood and this kind of stuff. So actually I find it easier to do those kinds of things because I am remote. So I used to have a technique that allowed me to operate open to deal with the blood and this kind of stuff, which is a psychological technique to allow me to do it, which actually I can get away without robotically, because that risk-taking thing I think is easier, because effectively you are risk-taking because you're overcoming the basic psychology of injuring people, because your brain is telling you I'm injuring this person, even though, and you have to get over that on a regular basis. So I think it does make that easier, and I think that makes it easier for female surgeons, because I think the risk-taking behaviour is more difficult for them. So we have a cohort of female surgical trainees who actually have real difficulty getting over the initial bit of making holes in people and this kind of stuff.
That's an interesting research project.
Yeah.
Yeah, just an extension of the question on risk, actually, how much risk do you think it removes because of the, I guess, the reduction in fatigue that it would allow to use a robotic system like that, as well as the fidelity that you've now got to...
So in terms of, when you say risk reduction, you mean for the patient?
Yeah.
So I think for the patient, we tend to work in outcome measures. So the outcome measure that I usually would give you is open surgery, it takes you 3 months to recover. Keyhole, laparoscopic, it probably takes you 4 to 6 weeks. Blood loss for open surgery, 500 mils to 3 litres. Keyhole surgery, 150, 200 mils. risk of not being incontinent significantly better with robotic surgery, risk that your erections are preserved undoubtedly better with robotic surgery. So it's all things like that that kind of mount up together, and there's evidence as well, certainly in my neck of the woods in prostate cancer surgery, that your risk of long-term complications is lower with robotic surgery. That's how we actually managed, because the government initially didn't want us to buy one of these things, that's how we managed to persuade them that this was the right thing to do. It wasn't on the cost saving, because there isn't really a cost saving at the index point. It's in the long-term complication rate is much lower, and as a result of that, you then have some cost saving, which is eventually what we managed to twist their arm to let us have one. Not that they paid for it.
Hi, Ian Phillips with the Oil and Gas Innovation Centre. Question about application. So you very much described that Da Vinci robot as your baby. So is it somehow trained or specific to the task that you do, the urological work, or in principle could it do any form of surgery? In
principle it could do anything. There's a guy in Belgium who even does vasectomies with it, which I don't understand why you would do. But you could do virtually anything with it. I think what you need to think about, what we think about, is whether it's worthwhile. So you could dock the robot and do a hernia repair, but a hernia repair in reality only takes 20 minutes, and to dock the robot takes 10. So you're adding an extra 10 minutes, and does it actually confer any benefit to the patient? Probably not. Probably does to the surgeon, because in terms of the ergonomics of laparoscopic surgery are horrible, whereas the ergonomics of robotic surgery are actually really nice, because you sit down, you're really comfortable, it reduces surgeon fatigue, it allows you to operate in an environment which is not prejudicing you, because you can alter the ergonomics of all those bits and pieces and make sure that you're in exactly the right position to achieve what you want to do. Whereas with laparoscopic surgery, you can sometimes be tied around and in all sorts of difficult positions, which put a lot of strain on the neck and the top of the shoulders and this kind of stuff.
Roger Skinner, BP. Can we extrapolate the robot an awful lot about learning and whether it could, because it has the inputs you're providing, actually take that set and the visuals and actually gain its own insights into what normally happens next and provide assist in some sense to more junior type consultants doing things?
So I suspect that is under development. So all the output from my robot goes straight back to Intuitive. So I suspect what they're doing with that is looking at exactly what you've just suggested. They haven't said that because, of course, that would be not in their interest to put that out in the public domain. But if logically speaking, they'll be doing two things with it. They'll be looking how efficient you are as a surgeon, because we log in, so they know who's operating. And by that, they'll be picking who they then take to train people. And then they'll also be looking at what's the standardised steps that they can simplify even further. I'm sure they're doing it, because that's the only reason they'd be collecting that kind of data. And when you sign up to buy one of these things, you have to sign up to that as well. Yeah.
Do we have more questions? Oh, on the left-hand side.
Steps in, there we are.
Thanks, interesting presentation. Keith Waldridge from IGAN. Just interested, since you've started using robotics, how that's influenced the training of junior surgeons?
So in Aberdeen, we've got a big training program anyway, so we do train a lot of people that come through. When you take on a new procedure, you shouldn't really start to train straight away, which is what we did. We said, look, we're not going to train anybody to do this type of procedure until we're comfortable that we've got it right and that we can then provide you with the right training to do. So we do what's called modular training. And by modular training, so we have 2 consoles, which is why we bought the 2 consoles. So that was very much, I like to train, so I want a console from me. So I operate on one, and then my trainee is on the second console. So they're not at the patient side, they're actually on the second console. That allows them to see exactly what I'm doing when I'm operating, because if you're watching it on a screen, it doesn't give you everything. But it also allows me to give them parts of the operation. So you don't give them the whole operation, you give them a little bit of it. So you give them the easy bit to start with, say, right, you do this bit now. that has advantages for them because they don't get fatigued because it's quite hard learning new things, and then they have to do that between 5 and 10 times till they prove to me that they're ready for the next step, and then the next step, and then the next step, and you build that up. But you don't then give them the next step plus the one that they've already done. You do the easy step, and then that allows them to concentrate on the next thing, and you build it up from there. And the advantage for the patient is that they're not getting their whole operation done by a trainee who's never done that before. They're getting a little bit that they've worked on and worked on and worked on. The other thing that we have is that we have a simulator. So it's all very well learning to do the operation, but with this thing you actually have to learn to drive it. And one of the off-putting things is people walk into theatre and go, holy moly, what the heck is that? How am I going to use that? And particularly if you're perhaps a little bit more senior, I think it can be quite daunting. So what the simulator does, it allows surgeons to sit down and learn how to drive it. So I liken it to driving a car. So I don't let any of the trainees near a patient until they can drive the car. So they've got to pass their driving test. There's a driving test for the Da Vinci machine before they go anywhere near actually operating in real time. And I think what it has done is the simulator has worked really nicely in showing which trainees are prepared to make the effort and which trainees aren't. So if you don't make the effort, you don't get on the robot.
Are there other questions for Justine?
Oh, thank you. Well, two questions actually. One is you mentioned briefly about your experience, but on average, can you tell what the time to performance for a doctor, for a surgeon in robotic surgery versus laparoscopy or traditional? How many months or patients or whatever other measure you need to get that person to a level that you feel comfortable?
Yeah. So I always used to say it took me 2.5 years to be any good at laparoscopic prostatectomy. Now, I wasn't obviously from a standing start when you did robotic surgery, but some of my colleagues were. And I would say actually that came down to about well within 6 months. So it's a vast scale of difference. And people who I had watched struggle with laparoscopic surgery, it's no hassle for them. They can do it easily with this. It takes out all that, if you like, counterintuitive learning that you have to do.
And the second question then is, okay, well, is there a difference in the gap between an excellent surgeon and an average or mediocre one? Does that gap stay the same in laparoscopy or robotics, or does it reduce?
I think robotics evens the playing field a lot more. I think robotics turns your average surgeon into a really good surgeon in terms of the results that are achievable and this kind of thing. And most of us are average. You have a few excellent surgeons, but I think it actually pushes everybody that little bit higher, because what you can achieve is so much easier to achieve it. It's definitely a factor of 10 a difference, I would say. I wasn't convinced about at all until I sat down with it, but it definitely is there.
Here. So following up from that, so we've got one in Aberdeen. How many other hospitals that have the same robots, and how do you see the future? Is all surgery will be done like that? What is the future like?
So currently in Scotland, there's one in Glasgow, one in Edinburgh, and the one in Aberdeen. And I would imagine the problem at the moment is the cost. So it's about roughly 1.1 million for each system, which at the moment, with the constraints of the health service, it really was a huge fight to get even one of those in Scotland, and to get 3. It was slightly easier because Aberdeen was first, and then nobody in Edinburgh and Glasgow likes to be too far behind us, as I'm sure you can imagine. So it was easier for them because we'd already done it. So what's happening in Aberdeen at the moment? At the moment in Scotland, there is actually only approval to do prostates on this system. However, we're not known for paying much attention for that kind of thing. So actually we do, and why would you? Because we've seen what this can achieve. So we do robotic bladder removal, which is a big deal, and what's called intracorporeal reconstruction. So we're one of the first units in the UK that have done that. And we do kidneys, and we've also because we had a bit of spare time, because actually this speeds everybody up. So we asked our colleagues who work in gynecology, oncology, we said, you know what, you're probably the next ones in, so they've started as well. So they do, one of the problems with gynecological oncology is endometrial cancer tends to be in very, very big fat women. And very, very big fat women are very difficult to operate on because they don't tolerate the operation very well, and it's really difficult to get past all the fat into the pelvis. So it translates really nicely into robotic surgery because you don't have to worry about the weight that you're supporting and this kind of stuff, because the robot doesn't care. It's fine. It doesn't get tired. Your surgeon doesn't get tired. So the results that you achieve for endometrial cancer are outstanding compared with what you could have achieved before. So we've let the gynecologists have it for, they get 1 day a fortnight, which is all we had spare in the operating time that we have. From my perspective, we are desperate to get the colorectal surgeons on board. So this is like things like low rectal resections, which is way down in the pelvis. Because there's huge amounts you could do with that. Pancreatic surgery as well, because it's very complex and in an area that's difficult to access at the back of the abdomen, lends itself very beautifully to it. And I think one of the other big health issues that I can see coming is oropharyngeal cancer, so that's linked with HPV and things like this, so we see an increased rise in that. And the robot lends itself beautifully to transoral surgery. So rather than taking somebody's neck away like this, then actually you just go down the throat and operate down there. So you can imagine the huge morbidity of one versus the other. So in Aberdeen, we're very keen to do that. As I say, we do try and ignore for some things that we think perhaps are a little bit too stupid, and actually our management are very sensible about that, because when you have a piece of kit like that, you're duty bound to get the most out of it. So that is what we do. We do try and get the most out of it, but we still don't have capacity to do everybody else. So we are trying at the moment in various sneaky ways to try and get an extra system in to try and then put everybody else on. But it's tricky when the government is saying, there's not evidence for this. There is some evidence.
Sorry.
No. In fact, we were behind the curve. So the company that makes it is Swiss, and their biggest sales area is the States. There's big litigation in the States because the way it was brought in the States was probably wrong. I'm not saying the way that we've done it is right. I don't think that was right either. I think somewhere in the middle would probably have been more appropriate. But the way that it happened in the States was basically when you were going for your prostate cancer surgery, people would pick up the phone and say, have you got a robot? And if the answer was no, the phone would go down. So everybody bought a robot. And the problem with doing that is if you're only doing 1 or 2 cases a year, your results are still going to be rubbish, whether you do it on a robot or whether you do it open. And this is why you see there's some litigation associated with the robot, because if you don't use any tool properly, then you are going to make mistakes. And this is what happens. If you use it properly, you don't get as many errors. And if you bring it in properly in a staged fashion, which is what we did, we've had no conversions, no serious malfunctions, and only 1 critical event, and we've done over, well, I'd say with the gynecologists, we've probably done nearly 1,000 cases now. So that's a really low rate, but that is down to the way that we brought it in, and rather than just saying, oh, let's buy one and go, that's not the way to do it.
I'm afraid we've just run out of time for questions. Thank you, Justine, for a brilliant discussion. I would now ask Luca, would you like to share any closing remarks?
Just add my personal thank you for it has been inspiring and fascinating. Of course, it's not too difficult to draw parallels to the industry. Difficult places to reach that remote operation, control of the detail. But I'm still very, very much impressed by the time to performance and by the quality, range of average quality, which is, of course, in an industry very much conscious of health and safety. And the potential risk is a key element for us. So I hope that there will be more opportunity to explore parallel and synergies between the various sectors. And thank you again for the excellent presentation, Justine.